Good evening, everybody. Today we have with us the 116th session of the Africa Healthcare Network Fireside Chat. Dr. Prakash Gudsookar, who's an assistant professor of medicine in the Division of Nephrology and Kidney Care, that is Clinical Advancement Research and Education Program at the University of Cincinnati, Ohio. Dr. Prakash completed his internal medicine and nephrology training in India and later did a nephrology and transplant fellowship at the University of Toronto, Canada, where and following that, he joined Cincinnati as a faculty in Feb 2020. His areas of clinical and research interests are quality improvement in acute kidney injury, home dialysis modalities, and onconephrology. He's currently pursuing a master's in clinical and translational research as in the principal investigator track. He serves on the editorial board as a member for Advances in Chronic Kidney Disease Journal, a member of the Position Statement and Education Committee of the American Society of Onconephrology. He's a mentor for the International Society of Nephrology mentorship program and for the NEFSIM nephrons. He's also on the advisory board of the National Kidney Foundation, Ohio. With this, I think the stage is set. Thank you, Dr. Gudsookar, for coming on. Extremely grateful for your time, and please take on. The stage is yours.
Absolutely. Thank you so much, Dr. Vincent, and everyone from the Africa Healthcare Network. I think it's a big privilege for me to talk to you about this topic, which is quite an upcoming. Thank you, Dr. Vincent, for the very kind introduction. So what I'm going to talk about is the cancer-kidney connection and what a general nephrologist actually needs to know about various drug toxicities and the various scenarios of kidney diseases which can potentially happen in patients who have cancer. I don't really have any particular conflict of interest for this talk. These are my disclosures, which already Dr. Vincent mentioned. Let's go through some objectives. I mean, I tried to cut short the talk as far as possible because this is a huge and a vast topic. It's like discussing the entire spectrum of nephrology with respect to cancer. So it's like going through your entire disease, all the diseases what usually a general nephrologist would see. But I'm just going to stick on to a very few case scenarios today because we won't be able to finish. So what I'm going to do is I'm just going to give you a description as to what the spectrum of onconephrology is. We'll go through some epidemiological data to see what happens in terms of kidney diseases in patients who have cancer. We'll review some spectrum of acute kidney injury from conventional agents like cisplatin, some immunotherapeutic agents, which is an upcoming area or an upcoming armamentarium in terms of cancer therapies. And we'll review some hypertensive disorders which happen from the targeted therapies. Talk something about pseudo AKIs, which can happen because of some therapies, and briefly touch base on some electrolyte disorders. What I'm not going to talk about is multiple myeloma amyloidosis because it's an altogether different talk, as well as glomerular diseases, especially the paraneoplastic glomerular diseases. So now why should we be worrying about onconephrology? So as an onconephrologist, I typically see all these things which have been listed here. And I'm sure some of you, if not all, might be seeing some of these cases in your practice scenario based on how much oncological inputs you have from your parent hospital or how much of practice your practice is formed by cancer patients. So these are the reasons typically why a nephrologist gets consulted or when your oncology colleague calls you asking for help. Just a word of caution. There is a lot of word soup I'm going to talk about. These are all newer agents, all these MABs, TINIBs, IBs, all these monoclonal antibodies and targeted therapies. This is quite a word soup. So feel free to interrupt me if something is not clear because I'm going to run through my slides. Let's look at some epidemiological data. So this is US data. From cancer.org. And what we see here is new estimated cancer cases. In males, it has been prostate, and in females, breast cancer. So this is the overall burden of cancer as of 2021. And what we see in the second figure onto your right is, if you see the red line, which is going up, is actually the predicted cancer deaths, which would have happened if we were to do the same things as what we were doing back in 1980s, thinking about cancer surveillance, monitoring of these patients, newer targeted therapy, newer diagnostic therapies, understanding of the cancer immunobiology. So that would have been a predicted cancer death, which would have been exponential. However, now we see, because of all these advanced techniques, which are there at our disposal, we see the line slightly plateauing off, and you see the trends in the blue line. And those are the number of cancer deaths which have been averted. But what are the implications of these averted cancer deaths is improved survival, but improved survival at the cost of chronic diseases like chronic kidney disease, acute kidney injury, hypertension, cardiovascular morbidity and mortality, proteinuric diseases, so on and so forth. So that's why for a nephrologist, knowing cancer therapies and different diseases in cancer is important. But I just want to touch base even about what the African estimates is, because this would be more relevant for people who are from Africa. So this has been published recently in 2022, which mapped actually the incidence of cancer across the entire African region. And it's striking to see, you see the incidence and the deaths. Actually, it is staggering number of deaths and the incidence. If you look from the 2020, which is actually the blue bar, to the red bar, which is actually the 2040 prediction. So not just oncologists, but we as nephrologists are going to see these spillover patients because of increased survival and various kidney-related complications. But let's see what the historical data is in terms of understanding what happens with acute kidney injury in patients who have underlying cancer. So this is a Danish study, which is around 10 or 12 years ago. It's a huge cohort of close to 37,000 patients. And the incidence of 1-year risk of AKI was 17%, which is quite a bit. At 5 years, the risk of AKI was around 27%. And the highest risk of AKI, understandably, was in the context of kidney cancer, because patients who undergo kidney cancer surgery, nephrectomy, they have increased incidence of AKI. Patients with multiple myeloma, they have increased incidence of AKI. So these are some more of cancer-related risk factors which can increase risk for developing AKI. Sorry, my animation went off here. Sorry. This is another study which is slightly more recent, around 10 years ago. This is the time around when Salahuddin and his group from MD Anderson's looked at their cross-sectional data. So as you know, MD Anderson's Cancer Center is one of the biggest cancer centers in US. And when they looked at their data, they saw at 3 months, when a cancer diagnosis is made, the risk of AKI is around 12%. And then as the stage of the AKI worsens, the risk of death also increases. So increase in the risk of AKI even from non-cancer world, we know increase in the stage of AKI increases the risk of death. And very interesting observation, actually, what they made is less than 20% of these patients were actually referred to nephrology, because oncologists probably did not find it significant enough AKI. And when the AKI really happened, the time had already passed. So it was very important for a discussion between oncology and nephrology to be there to manage these patients at a proper timeline. So sorry, 10%. I was wrong. Not 20%, but 10% were referred. Only 10% were referred to nephrology. So this is a Belgian study which actually looked at the incidence of C.A.R.E. in patients who have various types of cancer, and the cancers have been listed there actually. So you see the incidence of EGFR less than 60 is quite a bit in these patients. So why it is important? Because at the time of diagnosis, if a patient has chronic kidney disease, then the chances of patient developing an AKI because of various therapies is significantly high. Now that we have seen the epidemiological data, what we know now is the burden of the cancer is exponentially rising. The survival definitely has improved because of various reasons, but so is the chronic disease morbidity. There is an increased risk of AKI, and this all translates into an increased risk of CKD and increased cardiovascular risk. So now taking further, let's segue our talk into acute kidney injury syndromes, which can happen in patients who are being treated for cancer. I have selected a few prototype cases from my own practice, which I've seen, and I'm going to talk to you about the management and more so about the histopathology. I'm not going to go into too many details there, but I'm happy to take questions as we go. So taking into consideration acute kidney injury syndrome, this is how I visualize an acute kidney injury happening in a patient who has cancer. Standard, think standard. We have to rule out hypovolemia, pre-renal state, hemodynamic issues, other drugs, non-cancer drugs like non-steroidal anti-inflammatory agents, contrast administration. So these things definitely we need to rule out. But then the center part, what you see is those specific cancer-specific things which are important. So nephrotoxic drugs like cisplatin, ifosfamide, cyclophosphamide, hemodynamic perturbations, obstructive nephropathy, radiation therapy, infiltration, the cancer infiltration into the kidney can cause AKI. And on the right and the left, you can actually see the cancer and the patient's specific risk factors, which are more or less same as what one would see in a non-cancer scenario. So this is a general schema of how we think about an AKI, because you have to keep your mind really broad, because there are many other things which are happening simultaneously in a patient who has cancer or who is on therapy for cancer. So let's look at this cartoon of a nephron, and I'll show you which all drugs. So I'll walk you through the various classes of drugs which act on the various segments of the nephron, because once you know where that particular drug is affecting in the part of the nephron, you can direct your investigations based on that. But just remember, all these drugs, they may have an overlapping site of damage. So some patients may have vascular injury plus tubulointerstitial injury. Some may affect proximal tubule plus the distal tubule. So there will be a lot of overlap, what you will see here. So let's see vascular injury. So the classical vascular injury, what we see is in patients who get gemcitabine for, say, pancreatic cancer or T-cell lymphoma, doxorubicin, patients who are being treated for multiple myeloma with proteasome inhibitors, vascular endothelial growth factor. These are the targeted therapies which are increasingly being used in most of the cancer, commonly hepatocellular cancer, colonic cancer, glioblastoma. Then tyrosine kinase inhibitors, which are used in so many of the hematological malignancies. Then there is a close overlap between, again, the vascular and the glomerular, but I just thought of separating glomerular because there is a distinct entity of vascular endothelial growth factor induced glomerular disorders, or endothelial growth factor inhibitor induced glomerular disorders. Classic we know is the mTOR inhibitor. mTOR inhibitors we use routinely in transplant scenarios. So proteinuric states and podocyte damage, which happens from mTOR inhibitors, is also a well-known entity. Proximal tubular injury, classic pattern what we see is in cisplatin, ifosfamide. The Fanconi syndrome, what we see with cisplatin. Pemetrexate, methotrexate, these are all proximal tubular toxins. Interstitial toxins, cisplatin again, carboplatin, proteasome inhibitors, immune checkpoint inhibitors. I'm going to talk more specifically about immune checkpoint inhibitors later in my talk. Distal convoluted tubule, cyclophosphamide, ifosfamide. And then coming down lastly to the collecting duct, where we see methotrexate crystal deposition. And tumor lysis syndrome per se is not a drug toxicity, but I just threw it in because it causes the uric acid crystallization down to the collecting duct. So let's talk about the tubular toxins now. So in my next 8 or 10 slides, I'm going to talk about various tubular toxins and how they present with. And as I walk you through, I'll go through specific cases. So let's look at case 1. I'm not going to point out somebody to answer any questions here. I'll provide you with answer, but feel free to chime in if you have any comments or anything. So we have a 55-year-old man who has been diagnosed to have testicular germ cell tumor. He does not have any prior comorbidities, undergoes an orchiectomy with lymph node dissection. He undergoes chemotherapy. Nephrology gets consulted because after chemotherapy initiation, the creatinine is 2.1, potassium is 2.8, magnesium is 0.6. Dr. Vincent, I just want to confirm, do you use the SI system, or I mean, you use the milligram per DL or the millimole? What system do you use?
Millimole.
Millimole. Okay, so most of these values are in milligram per DL, but wherever necessary, I will point out which is abnormal then. So this patient has an AKI, so creatinine of 2.1 would probably correspond to a creatinine of say 160 or 180 in millimoles. Patient is hypokalemic, hypomagnesiemic, hypouricemic. Patient has protein of 1+, glucose 3+ in the urine analysis. There are some heme granular casts which are present which suggest a tubular injury. And patient is non-oliguric. What is the likely cause of acute kidney injury and the metabolic abnormalities what you are seeing here? So this is a very classic case of an acute kidney injury with simultaneous Fanconi syndrome, which is happening in a patient who receives either cisplatin or ifosfamide. So let's see, we'll talk about cisplatin nephrotoxicity. So how does cisplatin cause nephrotoxicity? So in the proximal tubular region, the cisplatin gets absorbed into or gets transported into the proximal tubular epithelial cell by the organic cation transporter 2, the OCT2, and gets concentrated into the epithelial cell. And now what happens is this concentration causes damage to the mitochondrial structure and a free radical oxygen radical injury. And that causes cell lysis and tubular injury. And that's why we get all these downstream effects of cisplatin nephrotoxicity. But what are the risk factors why a patient develops these things? It is because of chronic kidney disease, which is underlying, could be because of cisplatin peak levels, cumulative effect, old age, hypoalbuminemia. And these are the renal effects, what we typically see. We see like the classic acute tubular injury, acute kidney injury. We just see isolated salt wasting nephropathy. Isolated hypomagnesemia can be seen. Fanconi syndrome, which is described here in this case, distal renal tubular acidosis, and progressive chronic kidney disease can happen. And I'm just going to show you one example, which one of my friends provided me from Sloan Kettering. This is how the amino acid urea happens in patients who have cisplatin-related Fanconi syndrome. So you see this table here. Actually, it has been borrowed from their EMRs. You see all those red arrows which are going up is all the amino acids which are being spilled in the urine. So this is a very interesting way to show the amino acid urea, which is a consequence of underlying Fanconi syndrome. But can it progressively cause? So patients who have been treated with cisplatin, do they develop any residual kidney damage? So short answer is yes. And this is actually a study which actually looked at long-term kidney outcomes in adult patients who have been treated with cisplatin for various types of cancer. And they actually looked at 821. This is a study from Memorial Sloan Kettering from New York. And they looked into the patients across 10 years span. And they showed that acute kidney injury happened in 31.5% of their patients. And median, and what they did is they longitudinally followed these patients to 6 years. The median time to initial decline in the GFR was close to 3 to 4 years with a drop in the GFR of around 10 to 15 ml. So this is quite striking because even if remotely a patient has received cisplatin therapy, you can actually see the consequence with chronic kidney disease or acidification defects 3, 4, 5, 6 years down the line. So what are the principles of management of the cisplatin nephrotoxicity? Obviously, prevention. So there are no randomized controlled trials which have really looked at one therapy versus others. IV saline infused over 2 to 4 hours at the time of prior to and at the time of cisplatin is very helpful. Magnesium supplementation. Magnesium actually goes into the cells in the proximal tubule and reduces the effect of the free radical injury. Again, no randomized control trial. There used to be a conception of giving mannitol prior to cisplatin therapy. No longer practiced, but certain institutes do use it still if they are going to use high dose cisplatin therapy to help diurese and get the drug out. There is no role for dialysis per se, unless the patient develops severe AKI and you're dialyzing the patient for the AKI consequences. And there is some studies which are ongoing to look at nephroprotection by giving SGLT2 inhibitors. We might have some data maybe in next couple of years for prevention of cisplatin nephrotoxicity. So moving on to case 2. So we have a 50-year-old male who was diagnosed to have pulmonary adenocarcinoma with multiple bone metastasis and is initiated on pemetrexed. So pemetrexed is one of the newer versions of methotrexate. It's also a folate antagonist. So patient is treated with 500 milligrams per meter square every 21 days. Vitamin B12 and folic acid are also administered. His creatinine before starting pemetrexed is 0.6. So normal kidney function, normal electrolytes, urine analysis is bland. He undergoes 2 cycles of pemetrexed and the creatinine shoots to 3.2. So 3.2 would be roughly around 240 or 250 millimoles. The electrolytes are still normal. Urine analysis show 1 plus protein. The protein to creatinine ratio is 0.4. That is roughly around 400 milligrams of protein. And patient is not on any other nephrotoxic agent. Kidney ultrasound shows normal kidneys. There is no obstruction. After IV hydration with normal saline, there is no improvement in the kidney function. So what would a kidney biopsy show in this scenario? So we proceeded with a kidney biopsy and I'll show you the image. But before doing that, I'm going to talk to you about how does pemetrexed cause nephrotoxicity. So in this cartoon, actually, you can see pemetrexed, again, like cisplatin, gets concentrated into the proximal tubular epithelium. It gets absorbed through the basolateral side, gets concentrated in the tubular cell and interferes. It's a folate antagonist. And as we know, folic acid is needed for DNA synthesis. So it goes and disrupts the nucleic acid synthase pathway and causes tubular injury. So this disrupts the entire architecture of the cell, causing cell lysis. And because of that, what we see here, we see the histopathology of this patient. The first arrow pointing is at the tubular injury. What you're seeing, the sloughed off epithelium. You see some karyorhexis there in the nuclei. You see some vacuolization. You see on the right-hand side lower tubule, you can actually see the bubbly nature of the aggregates. It's actually the vacuolization what you're seeing because of pemetrexed toxicity. So what is the spectrum of kidney injury which happens because of pemetrexed? So we see proximal tubular injury with vacuolization. Long-standing cases, we can actually see cumulative effect leading to interstitial fibrosis, distal renal tubular acidosis, and in some cases, you see nephrogenic DI. What are the risk factors? Combining it with cisplatin or carboplatin can increase the toxicity. Cumulative doses, like what we saw in our patient, after 2 doses, patient developed toxicity. Prolonged exposure, and if the patient has deranged renal function at baseline. What are the treatment strategies? Prevention, B12 folate is given, hydration, and there is thymidine rescue. Basically, you provide patient with thymidine so that you at least mitigate some part of the nucleic acid disruption which is happening in the tubular cell, but this is more of a questionable therapy. And then there is a brother of pemetrexed, which is methotrexate. So methotrexate, as we know, causes tubular injury. It causes distal tubular injury. And in some cases, it can cause crystallization in the collecting duct. So what we see here, this is not my patient. I have taken this from Dr. Cooperman's lab from Arcana. And actually, classically, you see the tubular injury with sloughing of the epithelium. And you see that brown thing which is there in the tubule is actually the aggregation of the methotrexate crystals. How do you treat methotrexate nephrotoxicity? Aggressive hydration, alkalinize the urine, discontinuation of the medications that inhibit methotrexate excretion like probenecid, penicillin. So there is a therapy which is called as the leucovorin rescue therapy. It's basically you provide, you infuse leucovorin, which is basically a folic acid analog, and you try to mitigate the injury. There is another therapy which is used more commonly, which is called as the glucarpidase therapy. I'm not going to go into the details of that therapy right now, but glucarpidase is actually administered to high-risk patients who have elevated methotrexate levels or who get high-dose methotrexate. And hemodialysis can be used to remove the unbound methotrexate, but there is always a rebound of the methotrexate levels. So we may need more than 1 or 2 hemodialysis sessions to get the methotrexate levels down. Now, in certain scenarios, especially patients who are end-stage kidney disease who get methotrexate, there is a particular protocol to dialyze these patients after methotrexate infusions so that you remove the unbound methotrexate, because methotrexate, as you know, can cause severe bone marrow suppression. So to prevent other obviously in end stage, you're not worried about the renal effects at that point of time. What you're worried about other systemic side effects like profound bone marrow suppression. So we spoke about cisplatin, we spoke about methotrexate, pemetrexate, which are commonly used drugs and have a potential to cause tubular injury. Let's talk about tubular injury, but not from drugs. And the classic thing is what I'm going to talk now. So 67-year-old male who with chronic lymphoid leukemia failed conventional therapy, presents to the hospital for worsening leukocytosis. The WBC count is very high. The baseline creatinine is 1.4, so possibly around 150 millimoles, I would say. Patient is hydrated and the serum creatinine improves to 1.2. Patient is started on venetoclax, which is one of the newer targeted therapies. It is one of the BCL2 antibodies which is used in CLL. And 8 hours into the dose, the intern calls you with concerning labs with potassium of 7.5, elevated phosphorus, very high phosphorus, hypocalcemia, and a new onset AKI. So what is the most likely diagnosis here? How do you prevent the problem? What are the risk factors which caused the problem? And how will you manage this patient? So this is a clinical scenario which we commonly face as nephrologists. What I'm talking here about is the tumor lysis syndrome. And to diagnose tumor lysis syndrome, Cairo-Bishop criteria is already there in literature. So that's the most common thing which utilizes the various lab values and the clinical spectrum of the patient to see whether the patient has a definitive tumor lysis or a probable tumor lysis, whether the patient just has tumor lysis or whether the patient has tumor lysis syndrome. So lab TLS requires 2 or more criteria in 24-hour period. So like those lab criteria which have been listed there. And the clinical TLS requires lab TLS plus at least 1 or more of the clinical criteria. Like in this patient whom I've just presented, definitely has lab TLS, but also has severe acute kidney injury, which comes into the clinical TLS picture. So this patient has clinical tumor lysis syndrome. So this comes very handy, but most of the times, the diagnosis is pretty straightforward. So what do you do to prevent from tumor lysis from happening? You need to do risk stratification pre-administration of the chemotherapeutic agent. So how do you risk stratify the patients? So based on what type of cancer the patient has, you can have high-risk cancers like acute myeloid leukemia, acute lymphoblastic leukemias in pediatrics, Burkitt's lymphoma, or lymphoblastic lymphomas. Those which are slightly low risk are chronic myeloid leukemias, Hodgkin's lymphomas, solid organ tumors. There are certain features which put a person at increased risk. If it's a bulky tumor, huge tumor, lot of lymph nodes, a very high LDH, at least 2 times above the normal at baseline, because LDH is a marker of cell turnover. A very high WBC count, and cytotoxic therapies like cyclophosphamide is one of those agents. And what are the clinical factors? So what are the patient-centric factors? Underlying CKD, obviously, like all other AKIs. Baseline uric acid more than 7.5, and if the patient has underlying volume depletion. So what pathophysiologically happens in patient who has tumor lysis syndrome? So I'm shown here the cancer mass onto the on your left-hand side, and just amplified the cell. What is happening ultrastructurally is it interferes. So what happens is your purine pathway is involved here. Purine is converted into hypoxanthine to xanthine and uric acid. Because of the increased cell turnover, you generate a lot of uric acid, and that uric acid just goes and clogs the kidney. Now, how do you treat the patients? So you have 2 main therapies here. One is allopurinol, which is a xanthine oxidase inhibitor, or febuxostat, which is not available readily in United States, but I know in India it is readily available. And rasburicase, which is a recombinant uricase enzyme, which promotes the conversion of uric acid into allantoin, and allantoin is actually can be freely excreted in the urine. So talking about the pathophysiology, let's see what are the treatment strategies we have. Like I said, the prevention is the best thing here. Hydrate the patient, avoid hypovolemia. Urinary alkalinization has some doubtful role. Some people do practice giving IV bicarbonate. Upfront treatment with allopurinol, and in places where it is available, use of rasburicase. And treatment essentially is supportive. Manage the electrolyte disturbances, manage the volume, and whenever indicated, do dialysis. Conventional dialysis is very helpful here because you can actually clear off the uric acid which is circulating. You can use slow therapies. Peritoneal dialysis is not useful. So if a person is on peritoneal dialysis, develops tumor lysis, it is prudent to transition this patient to transient hemodialysis. But what is the head-to-head comparison between use of allopurinol and rasburicase? So allopurinol can be traditionally used in patients who are low to intermediate risk based on the risk stratification, patients who have normal kidney function at baseline, and pre-treatment uric acid level is less than 8. But in cases which are high risk, like say Burkitt's lymphoma, in patients in pediatric age, patients with impaired GFR, pre-treatment uric acid more than 8. All these are high risk factors. So upfront use of rasburicase has shown good outcomes. So what is the most likely diagnosis? We already spoke. It's clinical tumor lysis syndrome. How would you prevent it? Pre-chemo, hydration, upfront use of rasburicase. Risk factors. Yes, patient had high risk factors here. The WBC count was very high. And how would you monitor or manage this patient? Monitor electrolytes, urine output, kidney function, look for arrhythmias in the setting of hyperkalemia. Don't delay dialysis. However, there is no role for prophylactic dialysis. Like patient is high risk for tumor lysis. So prophylactically starting the patient on dialysis does not make sense. So wait for indications, but don't wait too long. So we have looked at all possible causes of tubular injury here. What I'm going to segue now into is the vascular toxicity, which is a big chunk, and actually is a big chunk of onconephrology practice. So before we go on to individual drugs, I want to show this slide to you, which just shows how the things have changed over past 2 decades. So if you remember in 2000s, in 2001, when the BCR-ABL monoclonal antibody, that is your imatinib, was, or tyrosine kinase inhibitor, not a monoclonal antibody, I'm sorry, it's a tyrosine kinase inhibitor, was introduced, the outcomes of chronic myeloid leukemia significantly changed. The survival drastically improved. But as investigations and as we understood the immunobiology of these tumors, you see the number of drugs which have come up in past 2 decades. It's so difficult even to catch up. That's why I said at the start, there will be a lot of word soup, what you'll be seeing here. So this is all beyond my cognition to really remember all these drugs. I can probably remember the major classes of drugs. And what is important is to remember what class effect a particular drug does, because individually you cannot remember all these. So let's see a case which I recently encountered. So 50-year-old woman with a history of non-resectable glioblastoma multiforme, brain cancer, is treated with Avastin infusion. So Avastin is bevacizumab, which is one of the vascular endothelial growth factor inhibitors. She does not have any prior history of hypertension, has a normal kidney function, and is referred to nephrology to evaluate new onset hypertension and proteinuria, very high blood pressure, creatinine is normal, and has 3.2 grams of protein. So what does this patient likely have? So this patient actually developed what we call as a classic symptoms of vascular endothelial growth factor inhibition. So if you see this cartoon here, the vascular endothelial factors, as they get inhibited, there is an imbalance between the endothelin levels and the endogenous nitric oxide. So the nitric oxide goes down, endothelin levels go up, there is increased in the vascular remodeling, there is podocyte damage, some amount of tubulointerstitial damage also happens, and this all leads to hypertension and proteinuria. So this is one of the common class effect of the drugs of what we call as the tyrosine kinase inhibitors or vascular endothelial growth factor inhibitors. There is a very classic lesion which is seen because of the vascular endothelial growth factor inhibitors, and it mimics what happens in pregnant females who develop preeclampsia. So there is glomerular endotheliosis or glomerular swelling which is seen in these patients. So this is what the glomerular endotheliosis looks like when patients are treated with ibrutinib, which is one of the agents which is used to treat the CLL. Just for reference, how a normal kidney biopsy would look like. That's your normal endothelial cell. You see the striking difference of the endothelial swelling in the other image. And this is the electron microscopy where you see this big endothelial cell, which is enlarged in size. So a classic manifestation seen with ibrutinib. How do you treat these vascular endothelial growth factor inhibitor induced hypertension or tyrosine kinase inhibitor induced hypertension? So because there is decrease in the endogenous nitric oxide levels and increase in the endothelium levels, you need to use agents which will probably provide some endogenous nitric oxide and also provide some vasodilatation. So RAS blockers, they have some vasodilatory effect. Also, it helps in reduction of the proteinuria. Calcium channel blockers, the dihydropyridine can be used. You can use long-acting nitrates because they provide endogenous nitric oxide. Don't use non-dihydropyridine, that is your diltiazem, because that will interfere with the drug metabolism because of the hepatic microsomal system. And diuretics, it is not that they are contraindicated. You have to use them with caution, especially in patients who have underlying cancer, because they will be confounded by other problems like volume depletion, nausea, vomiting. So be careful, not per se a contraindication to use these agents. Just to give you a list of these drugs, I'm sure these slides will be provided to you later. I have just enlisted various types of vascular endothelial or anti-VEGF drugs, which are increasingly being used in virtually all types of cancers. So you say skin cancers, prostate, non-small cell lung cancer. I showed you glioblastoma, hepatocellular, thyroid, renal, everything. And there is a high incidence of hypertension. So there is an upcoming branch in onconephrology now, which is called as the oncohypertension. Actually, we are actually looking at outcomes of patients who develop oncohypertension or hypertension because of the onco drugs. And you see these risk of hypertension is to the tune of 40% with axitinib, which is one of the tyrosine kinase inhibitors, cabozantinib, which is close to 60%, and levatinib, sorry, the arrow went in the wrong direction, but levatinib, which is 70%. You can see it here. Let's go on to a second case, more of a multiple myeloma spectrum, but I'm not going to talk about multiple myeloma. We'll talk about a thrombotic microangiopathy-like picture of what happens here. So 57-year-old woman treated with, who has failed prior chemotherapeutic regimens for multiple myeloma, is started on carfilzomib. So carfilzomib, like bortezomib, is a proteasome inhibitor. And as you know, proteasome inhibitor introduction in the myeloma therapies have significantly changed the prognosis of the myeloma process. So 10 weeks into the therapy, she developed severe fatigue and is found to have new onset anemia and thrombocytopenia. Her serum creatinine is up to 1.9, so that is close to 160, 170 millimoles. Her baseline is close to 80 millimoles. Her multiple myeloma appears to respond with decrease in the free light chains. So there is improvement in the free light chain. So this is very unlikely that the patient has fast nephropathy, because you'll always be worried of a new onset AKI happening in a patient who has multiple myeloma. But you proceed with a kidney biopsy because not sure what exactly is happening. And you actually see the classic thrombotic microangiopathy happening here. You see the fibrin deposits in the capillary loops. You see the arteriolosclerosis, which is happening here. So this is a classic thing which happens with carfilzomib, axazomib, and bortezomib. So clinical trial data shows that 15 to 20% of the patients who get treated with proteasome inhibitors can develop thrombotic microangiopathy. So think about thrombotic microangiopathy if patients are on these agents and develop new onset AKI with anemia and thrombocytopenia with presence of other systemic TMA-like symptoms. Why does TMA happen from proteasome inhibitors? So these are just the proposed mechanisms. We don't know yet, but it is probably because of antibodies directed against ADAMS13. There is a direct endothelial injury because of the drug itself. There is also a pathway through VEGF, which causes decrease in the vascular endothelial growth factor, which causes the similar downstream effects which I showed you before. So this causes thrombotic microangiopathy. Now I'm going to talk quickly about another drug which is notorious to cause thrombotic microangiopathy, and that is gemcitabine. So this is a patient whom I saw last year, who was referred to me by my oncology colleague who has T-cell lymphoma, was being treated with gemcitabine, referred to me for new onset AKI, marked proteinuria, and new onset hypertension. Complement levels were normal. I'll tell you why I'm talking about complements here later. ADAMS13 level is also normal. The activity is normal. And we get referred at a creatinine of around 2, that is 170 or 180 millimoles. That is the nephrology is involved. And we decide to do a kidney biopsy. Again, on the similar lines, what we see is florid thrombotic microangiopathy in this patient with endothelial swelling and fibrin depositions in the capillary loop. We proceed with plasma exchange for this patient. No benefit with plasma exchange. So we decide to give patient eculizumab, that is a terminal complement inhibition. Now, what is the data regarding plasma exchange and eculizumab in these patients? So there is a nice study which actually came from the French thrombotic microangiopathy research group, published in 2021, which looked at use of eculizumab in patients who have gemcitabine-induced thrombotic microangiopathy. And actually the hematological response, it was there. The renal response to the medication was not very impressive. Only a couple of patients actually had complete improvement in the renal recovery, but 2 patients did not recover. Other patient had partial recovery. So, but remember, this is an onco or hemat-centric manuscript, so not much of renal outcomes have been discussed in this case. But just to give you an idea, gemcitabine actually causes one of the most notorious forms of thrombotic microangiopathy. So I was talking about the complement level. So why I spoke about complements, or why we thought of checking complements, is it's important because some of these patients, you don't know, they might be genetically predisposed, may have some complement factor deficiency or factor defect or genetic predisposition to develop thrombotic microangiopathy. In a normal circumstance, probably they may not develop, but when they have a drug circulating which disrupts the endothelial activity, like say gemcitabine or say vascular endothelial growth factor, it can actually the cascade of the complement activation happens, and that is what we call as a second hit phenomenon, which happens over and above what the first hit is, which is your genetic predisposition. So always good to check. And if you demonstrate there is complement deficiency or complement activation or any complement defect, you are actually justified in giving patient eculizumab. So these are the various mechanisms, various drugs which oncologists used, and they have various ways in which they cause TMA through direct toxicity or immunologically mediated, or say like generation of antibodies. So it could be a toxic reaction, and it could be a dose and time dependent with a direct cellular or a direct endothelial damage, or it could be an immune reaction or an idiosyncratic reaction in which antibodies are generated against the endothelium. So these are the possible mechanisms. Just to bring up, not many institutes do hematopoietic stem cell transplant. Our institute is going to start doing hematopoietic stem cell transplant, but hematopoietic stem cell transplant in itself is a Pandora's box. If you open it, there are various reasons why a patient may develop thrombotic microangiopathy because of the acute graft versus host disease, or the drugs which are being used, that is the calcineurin inhibitors, or the radiation-induced radiation nephritis can also mimic as thrombotic microangiopathy. We know from the transplant world, adenovirus, cytomegalovirus can also cause thrombotic microangiopathy-like picture in the kidney. So there are various ways transplant-associated TMA can present. So in general, the principles of management of drug-induced TMA: drug discontinuation, supportive care, manage hypertension. Plasma exchange data is very sparse, and it is just based on a few anecdotal reports. Eculizumab, again, it is based on anecdotal reports. There is only one study which I already showed you. Unless there is a documented complement dysregulation, eculizumab probably won't work. In certain cases with Avastin or bevacizumab induced thrombotic microangiopathy, there has been some data to suggest eculizumab helps, but we probably need more systematic studies in this. And as you know, the numbers of these patients are so less, it's very difficult to really have a randomized study. So in summary, what we looked at is tubulointerstitial toxicity is common with some of these drugs. Vascular injury from vascular endothelial growth factors causes hypertension and proteinuria. Thrombotic microangiopathy spectrum, it could be a second hit effect from these drugs. And we need to identify tumor lysis syndrome early, risk stratify the patients, because the treatment, the prognosis of the patients is usually good, even though they develop tumor lysis. Let's talk about radiation therapy. So this is, again, big cancer centers where they are administering brachytherapies or abdominal radiation therapies. You may see a case scenario where I'm just going to describe you. So this was a patient whom I saw a few weeks ago, 48-year-old, not a hypertensive female, underwent abdominal hysterectomy for adenocarcinoma of fallopian tube. Pre-operative urine analysis and serum creatinine were normal. Post-op underwent radiation therapy for 8 weeks. At 12 weeks, nephrology was consulted because the blood pressure was very high. Patient had some blurring of vision, had new onset proteinuria. Serum creatinine was 3.2, so that is close to 250 millimoles. Kidney ultrasound did not show any obstruction. CT abdomen did not show any recurrence of her original cancer. So what was the diagnosis here? So we got the patient in and hospitalized, treated the patient with IV nicardipine, that is one of the calcium channel blockers, got the blood pressure down. Patient had 22.8 grams of protein, had some schistocytes, so had fragmentation, had high LDH. So this sounds and smells like a TMA-like process. We went ahead after stabilization of the patient, went ahead with a kidney biopsy. And the kidney biopsy actually showed a nice concentric onion skin appearance of the arterioles, where you can classically see even what we see in scleroderma renal crisis. And when you look at the glomerulus, you see the endothelial swelling and you see the fibrin deposition, which is very classic of thrombotic microangiopathy. So this patient had a systemic TMA-like process. Blood pressure was aggressively managed. With blood pressure stabilization alone, the creatinine did improve to 1.2. Proteinuria also improved from 2.8 grams to 450 milligrams. the peripheral TMA just resolved. So this was probably just a perfect description of hypertension-induced thrombotic microangiopathy. The workup for atypical HUS fortunately was negative in this. And if you were to summarize what various types of injuries, because if you see radiation therapy could be a multi-pronged effect, it can virtually damage any part of the nephron. It can cause hemodynamic vasoconstriction, cause podocyte injury. We can see endothelial injury, mesangiolisis. You can see TMA, fibrin thrombi, and acute tubular and interstitial injury. So virtually any compartment can be injured. If you look at the natural history, since the time a patient gets radiation therapy, till various spectrum of events happen, you can have acute radiation nephritis, which is quite within one, which can actually happen within a year of the treatment, or it can get prolonged as long as 18 months, where patient develops chronic hypertension and then subsequently develops chronic kidney disease. So this is just to show the spectrum of hypertension disorder. Now I'm going to get into an important area, which is called as the immunotherapies. Immunotherapies, as you know, has been utilized for all new this is a new drug which has increased usage in last 5 or 6 years, and virtually all cancers are now amenable to immunotherapeutic agents. But our understanding of this immunotherapeutic agent is based on, I'll show you how things operate. So you see here is on the tumor side or the cancer microenvironment side, you see the cancer. The cancer actually releases tumor antigens. These tumor antigens, they go into the lymph node and bind with the dendritic cell, which is also the antigen presenting cell. These primed dendritic cells, they go and activate the T cell. Now the activation of the T cell happens with the co-stimulation. Now we know the co-stimulation blockade, which we use in our transplant, the belatacept and the CTLA4 antibodies. So this is around the same lines. So the T cell gets activated, and after the activation of the T cell goes back to the cancer microenvironment and binds with the PD1 and the PDL1, that is the programmed death 1 and the programmed death ligand 1 receptors, which causes the downstream destruction of the cancer. Okay, but the PD1 and the PDL1 interaction is called as the immune checkpoint. It's like a brake. It's like a policeman who is instructing the T cell not to get overactivated, not to get hyperactive. So it always keeps a check or keeps a brake on the activity of the T cell. Why it is important is because if there is no immune checkpoint in you and me, these T cells will relentlessly progress and cause autoimmunity. So this is very important. So what scientists looked at is, what if we dismantle this immune checkpoint? So if we remove the brake and allow the T cell to relentlessly kill the cancer. And this was actually discovered by 3 main scientists. One was Dr. Tak Mak from Princess Margaret Hospital in Toronto. He discovered the T cell receptors. Dr. Jim Allison from MD Anderson, who discovered the immune checkpoint in 1995. He won the Nobel Prize in 2018 for physiology and medicine, along with Dr. Honjo from Kyoto University in Japan. They shared the Nobel Prize for the discovery of immune checkpoint inhibitors. And since then, the immune checkpoint inhibitors have completely invaded into the realm of the oncology world. But just going back to what happens is, so you see, I just amplified what the immune checkpoint would look like. And there are certain antibodies which will be directed against the PD1 and the PDL1. And the PD1 antibodies are what we call them as nivolumab, pembrolizumab, and the PDL1 antibodies are the atezolizumab, then avelumab, and durvalumab. So a lot of mAbs, but the main mechanism is you harness your innate immune system, unleash the natural brakes which are mediated by these immune checkpoints through the PD1 and the PDL1 interaction, thereby allowing your T cells to relentlessly attack the cancer cells. So it's just like just like a relentless fight between two Jedi Masters and the Sith Lords, if you were to do a Star Wars analogy. These are the agents which have been approved. This may not be an updated list. I need to update this list, but this is the same drugs which I previously showed you and the various indications. So practically most of the cancers can be treated with immunotherapy. So let's see a couple of cases which actually look at the toxicities with these drugs. So 60-year-old male, non-small cell lung cancer with a PD-1 staining of 52% is started on pembrolizumab. Baseline creatinine is normal, has an underlying history of gastroesophageal reflux disease on pantoprazole. They're admitted with AKI 2 months after the initiation of pembrolizumab, which is one of the PD-1 inhibitors. At admission, the creatinine is 8, urine analysis shows no protein, WBC is 15 to 20, no RBCs, and there are presence of WBC CAS. Kidney ultrasound does not show any evidence of obstruction. So what did the histopathology diagnosis show? So what I'm showing here is a very classic manifestation of immune checkpoint inhibitor induced acute kidney injury or acute interstitial nephritis. You see the entire field is studded with lymphocytic infiltrates. You can see occasionally a few eosinophils actually from the last pointer. So this patient had the classic symptoms of immune checkpoint inhibitor induced AKI leading to acute interstitial nephritis. So what is the principles of management of ICPI AKI, also called as the immune checkpoint inhibitor AKI? The risk factors, patients being on proton pump inhibitor is an associated risk factor. Presence of extrarenal immune related adverse events like say thyroiditis, pancreatitis, colitis in the remote past can be a risk factor for development of immunological reaction in the kidney and impaired GFR at baseline. Do a kidney biopsy whenever feasible. AIN is the most common lesion which is seen. There are certain non-invasive tests which I have listed here, which are like the biomarkers which can be used for the AIN process. And treatment, treat early, like in any other acute interstitial nephritis, treat with steroids, with rapid taper over 4 to 6 weeks. Initiation of steroids within 14 days had good prognosis. Within 3 days of initiation had still better prognosis. So there is actually an immune checkpoint inhibitor AKI consortium, which operates through the Brigham Group at Mass General Hospital, and they try to collect all the data for the immune checkpoint inhibitor toxicity. This is another interesting case, more of a GI case, but we get consulted because of the reason I will show you now. So 65-year-old male metastatic non-small cell cancer of lung treated with PD-1 inhibitor comes in with an AKI creatinine of 4.5, baseline is 0.9, urine sodium is less than 10, septic workup is normal, C. diff stool oviparasites are normal, treated with IV fluids, the diarrhea persists, and the GI is consulted, and a colonoscopy and biopsies performed. Now, we are not gastroenterologists, but I'm just going to tell you that what we are seeing here is actually an immune-related colitis, which is happening. So this patient developed severe lymphocytic infiltrate immune colitis, was started on prednisone 40 milligrams a day. The diarrhea subsided within 2 days, and the kidney function improved with hydration. So another spectrum of immune-related adverse event. And one more to just wrap up the immune checkpoint inhibitor toxicity. Patient was started on nivolumab, which is one of the PD-L1 inhibitors, admitted with fatigue, anorexia, hypotension. AM cortisol was noted to be low. And even after ACTH stimulation, the cortisol remained low. CT abdomen did not show any evidence of adrenalitis. MRI brain showed no features of hypophysitis. But still, there was a suspicion that this patient had a primary adrenal insufficiency. So probably this patient had central adrenal insufficiency, treated with IV hydrocortisone, hypotension improved. So this is another endocrinopathy which can actually happen with with immune checkpoint inhibitors, and we get consulted because of that, because of the electrolyte abnormalities which are seen. I am just wrapping up just a couple of slides, so bear with me. I'm going to talk about pseudo AKI, not very commonly seen by a general nephrologist per se, unless you are really associated with a big cancer institute, because these are newer drugs which are in clinical trials and which are coming into therapeutics now. I'm sorry, wrong sequence here. So a 65-year-old man is diagnosed with lung cancer with MET exon skipping mutation. So don't worry about what MET exon is, but it is one of the characteristics what oncologists look into the cancer to treat with a drug which is called as a MET kinase inhibitor. So capmatinib is one of the MET kinase inhibitors. And a very interesting mechanism of action of capmatinib is it can cause an artifactual elevation of creatinine. So in this patient, the creatinine went to 1.8. The urine analysis was normal. We checked cystatin C in this patient. I'll tell you the reason why later. So cystatin C was normal. So this patient had an artifactual elevation of creatinine without true acute kidney injury. Okay, so it is very important to understand, because if you don't know if this is a pseudo AKI or a real AKI, you may inadvertently stop an important therapy what the patient is getting. But what is important to understand the physiology behind it is these drugs, they act through the MATE1 and 2, the OCT1 and 2, and OAT1. So MATE is actually, it's one of those transporters which are there on the proximal tubule, the organic cation transporters and the organic anion transporters. So I'll show you a list of drugs which actually operate through various transporters. And again, these slides will be available for you. It's a lot of word soup here. Even I don't remember all these drugs. I have to go back and refer to them through what mechanism they cause the problem. So they can actually cause inhibition of secretion of the creatinine, causing the creatinine to go up, leading to pseudo AKI. So these are the drugs. I think that's my last slide. I just want to touch base on the electrolyte abnormalities which can happen in these patients. So this is a patient who was treated for oral squamous cell cancer with docetaxel, cisplatin, and 5-fluorouracil. 6-month follow-up, patient had disease progression and was started on a monotherapy of cetuximab. So cetuximab is actually an endothelin, an EGFR, that is an epidermal growth factor inhibitor, epidermal growth factor receptor inhibitor, EGFR inhibitor. After 2 months of therapy, the patient presents with fatigue, weakness, lightheadedness, and muscle twitches. Blood work, sodium is normal, potassium is normal, chloride is normal, bicarb is normal, creatinine, kidney function is normal, glucose normal, some hypocalcemia, and very severe hypomagnesemia. So I just posted a question here. You don't need to answer it, but what I'm hinting to is cetuximab actually causes the EGFR blockade. And I'll show you in the next diagram here. It actually blocks the EGFR, which is there on the basolateral. It competitively, it is a competitive inhibitor with the epidermal growth factor. Now, epidermal growth factor binding to EGFR is very important for the magnesium regulation. So magnesium reabsorption from the apical side is important through the EGFR pathway. So once the EGFR pathway is blocked through the TRPM6, the magnesium reabsorption does not happen, and all the magnesium is actually dumped into the urine. So patient become hypomagnesiemic. So very important, actually, clinical trial data shows 25 to 30% of the patients who get treated with this agent develop severe hypomagnesemia. Just a table to show you various electrolyte abnormalities which can happen with these targeted therapies and immunotherapies. You can see virtually any electrolyte abnormality with these things. So a baseline knowledge of these electrolyte disturbance in the setting of these cancer therapies is extremely important. So trying to wrap up my talk here. So what we looked in the entire last 1 hour, 10 minutes is we described the epidemiology of kidney disease in the setting of cancer. We reviewed some common causes of acute kidney injury through tubulotoxins, vascular toxins, We reviewed kidney-related adverse events in the setting of immunotherapies, which is increasingly getting, we are seeing more and more cases because of the increased usage of these drugs. We looked at radiation-induced kidney injury. We saw how a TMA spectrum can happen in the setting of these drugs. We looked at certain instances of pseudo-AKI and how it is important for us is to know the occurrence of pseudo-AKI so that we don't stop or don't ask the oncologist to stop the drug. And we did some brief overview of electrolyte disorders, which is unique to cancer and its therapies. So in short, it's very important as a nephrologist, because if you see the literature in oncology is expanding like wildfire. It's daily new drugs are coming up, new trials are coming up, and it's difficult to catch up. So it's always good to have a discussion with the oncologist. Hey, what do you think about this drug? What does this drug do? What are the side effects? You can go back and read. So there is a constant reading and active self-education which is involved if you're practicing onconephrology. So very important discussion with the oncologist, because eventually your decision on whether to stop the drug will be determined finally by the oncologist. So have a friend in the oncology division. For more reading, if you all want to read, we just last year we published the Advances in Chronic Kidney Disease, which is a bi-monthly journal through the National Kidney Foundation. We did 2 parts on so close to 25 manuscripts on just the entire spectrum of onconephrology through my colleagues in Northville and Mass Brigham. So it was a 2-part issue. Last year, American Society of Onconephrology was established. That was the inaugural year. We also have a Journal of Onconephrology, which is not yet PubMed indexed, but soon will become. This is the Onconephrology, American Society of Onconephrology website. We had our first symposium last year. So I would encourage people who are interested in onconephrology to join the society. This year's onconephrology symposium will be in MD Anderson's in Texas, Houston. Okay, so that was my marathon run and marathon talk about onconephrology and cancer kidney interaction and connections. I'm free to take any questions. If not now, you can always email me or reach me out on Twitter, or I can always share my phone number. Thank you.
Thank you very much, Prakash. It was a wonderful session, comprehensive, yet covered the whole of onconephrology, I would say. There's so many good cases. Nephrotoxicity, drugs, radiotherapy, causing TMA, immunotherapy, the checkpoint inhibitors, pseudo-AKI and electrolytes. So I think we have some questions there. Let's get on to the Q&A. Dr. Krabi has one question. How do we differentiate drug-induced TMA and other causes of TMA? Do you advise using eculizumab given its expensive price and only anecdotal observations?
Extremely good question. And the short answer is we really cannot differentiate. It all depends on the timeline through which these events happen. I mean, if a person has a cancer, you start a particular drug which is known to cause TMA. And if TMA happens, the temporal relationship with the onset of TMA probably just gives you a clue, but there is no histopathological way in which you can say whether this is a cancer-mediated TMA or this is a drug-mediated TMA. So it's always very difficult, and it's an ongoing battle between oncologist and nephrologist/hematologist to say what caused the TMA. Do you advise using eculizumab? The data on eculizumab is based on anecdotal reports. So we don't have a systematic study which has looked at these things. Again, if you are able to prove that in your patient there is complement dysregulation, yes, then you are justified, because then that's the only available therapy which can prevent the downstream cascade for the terminal complement pathway inhibition. So I agree. It is just
another question from Dr. Ben Lomataya. Thank you, Prof. What is Cairo Bishop name? Cairo Bishop name? Is it name of people or places? Kindly clarify this.
It's the name of the people.
People.
Okay. Would you re-expose patients? Okay, another great question. I purposefully did not talk about it because talking on immune checkpoint inhibitor is again a lecture and a talk in itself. But I'm going to give you a short answer to this. So ASCO, American Society of Clinical Oncology, actually say that if someone develops a stage 3 AKI or goes on dialysis because of that AKI in the context of immune checkpoint inhibitor, you should not start this patient back on immune checkpoint inhibitor. That is, don't re-challenge. But now, as we understand more and more, and as we pick these cases early when the AKI happens, we upfront treat these patients with steroids and mitigate the response of the inflammation. But it is important to understand these patients, these therapies are lifeline. Immune checkpoint inhibitors actually have shown to improve the cancer course significantly in many cancers. So it happens in certain instances that you re-challenge these patients with close monitoring under cover of steroids. Now, there is some data from MD Anderson, which they actually presented their data last year, is looking at infliximab use in patients who develop immune checkpoint inhibitors, but then are at risk of re-challenge induced AKI or AIN. So various therapies, even tocilizumab is being thought about for treatment. So short answer, yes, you can re-expose them, but it has to be a very closed monitoring and discussion with the oncologist.
Thank you. So the next question he says is, what drugs are available in Africa? Honestly, I'm not sure of this. I'm not sure what newer drugs are available because I've really not been treating onconephrology. I think we have Dr. Twair, who's a senior consultant nephrologist in Nairobi. Dr. Twair, would you can you enlighten us if any of these drugs are available in Nairobi? Because I'm not sure of the answer. I don't know the answer.
Yes, Lloyd, good evening. Thanks, Professor, for such an amazing talk. Yes, we have a lot of newer drugs for cancer. We have Avastin. Clearly, Avastin is available in most countries now. It's well used. We have a lot of the checkpoint inhibitors, the tyrosine kinase inhibitors. So I think this was a very timely lecture because these drugs are now coming up and the increasing availability. So it's good that we know how to use them and also how to mitigate some of the complications that they might cause.
Thank you very much. Any other comments, Dr. Twair? Thank you very much.
Not really. This is a very interesting topic, so I tuned in to learn a lot about it because onconephrology is becoming very important. So I also learned a lot in this talk.
Thank you so much, Dr.
Yeah, it's Dr. Not the same, but it's just sitting next to me. Now, well, I think I would like to thank Prof for this very interesting talk that has introduced another discipline in medical practice. As I was going through, I thought of in the transplant nephrology, which we know is associated with growth, so it's a high risk kind of situation for provoking cancers like post-transplant lymphocytic disorders and so on and so on. And knowing that a transplant already a chronic kidney disease state, and well, I thought he was going to mention about it, but to me, it looks like having a post-transplant patient who has developed a lymphoproliferative state, meaning who has developed a cancer, and you have to put him on a number of these drugs which are not being nephrotoxic. It feels to me like he's actually walking through a minefield. I would like him to make comment on that. And second question again, he's kept on mentioning thrombotic microangiopathy, but I kept on asking me now, is it both hemolytic uremic syndrome and the thrombotic thrombocytopenia? And to me, it sounds like most of it was thrombotic thrombocytopenic purpura. I would like him also to comment on that. Thank you.
Thank you for the question. So first question, again, I mean, I purposefully did not go into the transplant onconephrology part because that's again a lot of discussion, and there are a lot of unknowns there yet, because most of these drugs, so originally when all these drugs, especially the immune checkpoint inhibitors and targeted therapies were tried, they were all tried in patients who have normal kidney function. Classically, patients who have had kidney disorders or kidney diseases have been excluded from all these clinical trials. So, so obviously, kidney transplant patients were never a part of these original studies. As we see more and more patients being treated who have cancers with these immune checkpoint inhibitors or targeted therapies. Now, like I showed you, immune checkpoint inhibitor unleashes the immune checkpoints or the brakes on the immune system, thereby letting the T cells relentlessly progress. So there is always a risk of rejection which is involved with these patients when they are treated. But now there are certain places like Mass Brigham at the Mass General Hospital, they're systematically looking at data of incidence of acute kidney injury, rejections, and cancer response in these patients. So we'll have some more data. Dr. Murakami, who is from Mass Brigham, actually is looking at this data specifically, and they have actually devised some specific immunosuppression protocols to manage patients who have ongoing cancers and are being treated with immune checkpoint inhibitors. And I can always share those protocols with you. Those are already published. It's also there in the manuscripts which we recently wrote. So I can definitely provide you with that. Offhand, I won't be able to tell you the protocols because there are quite a few things in that. But obviously, first thing foremost, you always stop all the anti-proliferative agents, that is Cellcept or Imuran. If a patient develops cancer, maintain them on calcineurin inhibitors, low-dose steroids, add mTOR inhibitors along with the cancer therapies. So I hope that that answers your first question, Dr. Etienne.
Yes, it does. And in fact, that's why I said that, you know, in transplant oncology now it is like walking through a minefield. You are not very sure.
So transplant onconephrology.
Put your foot.
So transplant onconephrology actually can be a talk in itself, and there is a lot of new things which are happening so actively because it's like a double immune thing. You're already immunosuppressing the patients, plus you have an ongoing cancer, which is another immune problem, plus you're treating them with certain drugs which harness the immune system. So it's like the immune system is being targeted on 3 fronts. So it's a very interesting topic, which we can talk or discuss at some other time, maybe. But I probably did not clearly understand your voice was breaking on my end for the second question about the TTP. Yeah,
the second question, you know, you kept on referring to thrombotic microangiopathies. The question I was asking, do you get all you know, your TTP and the HUS, multiglutamic syndrome, and the thrombocytopenic purpura? To me, it looks like those cases, and the slides you are showing looks me more, you know, all of them were thrombotic thrombocytopenic purpura. Do you also get cases like that with multiglutamic syndrome?
Yes, we do. I mean, I have seen one patient who had developed atypical AHUS or atypical hemolytic uremic syndrome. I mean, obviously, you know, thrombotic microangiopathy is like a syndromic diagnosis or a blanket, an umbrella diagnosis in which various disorders, including atypical HUS, TTP, everything comes under as a spectrum in the TMA disorders. So we actually just submitted a manuscript 2 days ago for the seminars on nephrology, and I can share it with Dr. Vincent once it comes out. It basically discusses about the various spectrums of thrombotic microangiopathies which can happen in the setting of cancer. But to answer your question, I just kept it as a thrombotic microangiopathy as a blanket term, just to be in generic. But yes, we sometimes can see atypical HUS where you see the complement dysregulation, or like a TTP-like syndrome, which we actually saw in the patient who had the radiation therapy. So we do see those syndromes. Atypical HUS is not that common, but that's why what I recommend is to check for the complement factors and complement dysregulation in these patients, because these patients may be genetically predisposed, which is like a first hit, and then the drugs or the radiation therapy or the cancer, or whatever it is, will act as a second hit phenomenon, causing the complement dysregulation to progress and cause presentation like an atypical HUS.
Thank you very much.
Thank you. That's very, very interesting indeed. Phenomenal talk. I mean, there's so much occurring in onconephrology, and it's no wonder it's now probably will take off much more than a branch. I would say it will be a huge field in the coming years, because the drugs are so many as well. And as you said, it's so difficult even to see that list. Forget remembering, or you'll have even referring, getting the name to refer the drug is going to be a challenge.
Absolutely.
Thank you so much, Prakash. If there are no more questions,
Absolutely.
we come to an end. I think we'll call it a day. Thank you so much, Prakash.